Well, good afternoon, everybody, and welcome to this EPR Network webinar session. I'm Hadley Stoller, Chief Exec of Healthcare Innovation Consortium. I'm thrilled to be joined today by Joe Kelly, who's the Chief Nursing Information Officer at Kent Medway, and Mark Hutchinson from Altera Digital Health. So just while we're waiting for some more people to arrive, just some kind of housekeeping. So we've kind of muted your ability to be able to speak, but not your ability to be able to kind of pose questions. So there is a Q&A function at any time. We'll be monitoring that throughout the webinar. So please do post your questions and we will try and get to them. We are recording this session and we will send the recording out to you all within the next day or so, and you'll also receive the slides that we talk through as well. Just while we're waiting for a few more people to arrive, please feel free to pop in the chat kind of where you're from and your LinkedIn profile and email if you're happy to share that so that we can connect with you offline. This won't be death by PowerPoint. We've got a couple of slides that we want to go through, and then it's an open kind of webinar where we'll kind of talk through some questions. And hopefully, you'll find it really, informative. And, as I said before, please do contribute to the conversation through the chat. And hopefully you will have an enjoyable time with us. So obviously we'll be talking about some other things as well, including the EPR network a bit later on. And if you're joining from a mobile device, you won't be able to access the Q&A feature, so you'll have to put the questions in the chat instead. I think at that point we'll make a start just on the first slide. So just a little bit from me and a little bit about Healthcare Innovation Consortium. So we are an independent consultancy and we specialise in kind of digital health transformation. We partner with healthcare organisations and suppliers to really deliver those evidence-based strategic and sustainable solutions, whether that's around discovery, implementation, or evaluation and success. In terms of some of the work that we work with partners on and produce, everything from kind of readiness and maturity assessments around digital health, including EPRs, procurement guidance, making sure that the specs and the blueprints that you're kind of putting out there are really evidence-based and sound, options appraisals to make sure that the best fit solution has been identified, implementation and utilization support, so around deployment, optimization, cultural change, etc. on the ground, which we'll be hearing a little bit about today, and then benefit realization. So that's health economic evaluation and benefit kind of measurement. And we do that through a wonderful blended team, some of which you can see there and on the call with me today as well, clinical and technical and delivery folks. And we obviously also curate and run the EPR network and summit, which this is part of, and we'll hear a little bit more about that later on. So that's all from me. So without further ado, I'm going to hand over to Mark Hutchinson from Altera, who's going to take us through a couple of slides, and then we will open up the conversation. So over to you, Mark.
Thanks, Hadley. Good afternoon, everybody. My name's Mark Hutchinson. I am currently responsible for sales and solutions at Altera and have been for the last couple of years. But prior to that, for 25 years, I was in the NHS, and for 20 of those, I was the CIO in a series of different large acute organisations. You don't need to keep flicking back to this, Hadley, but it keeps jumping on, don't worry. But really all this slide says is, we've got a number of clients, I think 13 in the UK, who all use our product. That means that there's 9 million people in this country whose care is supported and provided on the basis of using the Altera EPR. And it's great that there's such a big network of people out there who are using the system to improve the safety and reliability of care. And the quote there from MTW is that it's really helped them to be innovative and to create transform pathways by having such a flexible EPR. And certainly for me as a CIO, what I wanted was flexibility. What I wanted was a tool that we could configure, that we could change, that we could make sure that our EPR matched the way that we worked. And if we needed to change things, then we could change things without having to, send a CCN, sign a CCN, pay a load of money to a supplier. So, the flexibility of the EPR, I think, is really powerful and really important for NHS organisations, and in order for you to be able to deliver, the maximum levels of usability for your colleagues, in order for them to be able to provide the best care to their patients. And I'm going to hand over to Jo to introduce herself.
Hi everyone, I'm Jo. So I'm the CNIO at Maidstone and Tunbridge Wells. I have been a CNIO at Maidstone and Tunbridge Wells for 3 years now, very soon. So I wasn't lucky enough to be there when they went live with the EPR, but I joined a year or so later, before we went live with EPMA and some of the other functionalities that we have introduced since. It's been pretty transformative for us as a trust. We went from a heavily paper-based analog system to the EPR pretty much overnight. So you can imagine the sort of culture shift and change that had to take place, that we've supported colleagues through that. It's provided us so much more data and so much more insight into how the hospital runs and how it works and what we deliver for our patients. So it's been fantastic. So, and the journey has not stopped. It never does. It continues all the time. So we've got a really good working relationship with Altera and continue to introduce new things all the time or amend things as we go along.
That's great. Thanks, Jo. Couple of questions then, just to start the conversation. I'm sorry that most are directed at you, but let's have a conversation as we're going through. And as I said before, to everyone on the call, please do put comments and questions in the chat and the Q&A box as we're going along. So obviously, as someone, Jo, working on the ground in a clinical setting, what would you say has been the most impactful usability change that you've seen in your trust EPR system that directly reduces stress or improves care?
So I've got quite a few examples, so please do stop me if I don't stop talking. I suppose the sort of biggest one is, the introduction of having sort of streamlined speciality-specific clinical documentation. It's really has been quite transformative to design the right documentation for the right users. So sort of switching from generic text-free boxes, free text boxes, sorry, even though clinicians do like them, we know it's difficult to collect data and information on those. So we have a real mixture within our documentation, which is great. Hopefully it's reduced some time and really given them a clear focus on what needs to be done. So reducing sort of that documentation fatigue. Another example for us is tab integration. So we've brought everything together into our main EPR, and then we've got tab integration to navigate our users out into supporting systems like PACS and our share care record as well. And this is in context launching, so it enables users to, at a click of a button, be able to see those scans that's relevant to the patient, or be able to understand what their community service and support is for them. So they're sort of two things that I think really, from a usability point of view, you don't have to click through loads of different and remember loads of different passwords. You're not navigating out the system and looking for a patient. So patient safety, obviously, having that in context launching is huge. We've also, for us, sort of the flexibility to adapt the EPR as well to suit the users has been brilliant. So We've recently started pulling useful information for clinicians into one clinical summary. So it's like one view for them. Or we've done some recent work responding to patient safety incidences, so we can add remove fields quite quickly. We've got an in-house configuration team that are fantastic at, and very quickly able to change things. Also enabling that important data to flow for auditing and improvements. A clear example for me is our recent work with VTE. We've amended the way we record the assessment because it wasn't working, which is fine. I think this is definitely a learning curve for everyone. You can't just put a piece of paper that you had into a digital system. You want to digitalize it. You want to make it easier for people. You can reduce things. You can obviously pull information to sort of streamline some of that. But our assessment wasn't working. For lots of reasons. So we've added some sort of mandatory fields. And also one of the things that we really noticed that staff, because of the way drug charts are now, because they're all digital in a system and they're not next to the VTE assessment like they used to be in a paper document, we had to sort of change the way that worked, and we've added a placeholder within the drug chart even if an anticoagulation isn't indicated. So whatever the prescription is for that VTE, it will go into the work list, so we know that someone has deliberately added that and completed the assessment. So that's something that's really been quite transformative in looking at patient safety instances and how we can respond to them to ensure that it's as safe as possible. And then another big example for us is the recent automation of vital signs. So this is automated from the device, the blood pressure machine, directly into the EPR. So that reducing time burden and transcription errors. And this is something that came straight from the users. So it was an issue they wanted a solution for. So we worked with Baxter and Altera to deliver this for them. So lots of examples there.
Awesome. Mark, I don't know if you want to come in and maybe just kind of comment on some of those. Obviously, I know you've obviously been part of the team with Joe to make some of that happen. Any thoughts?
Yeah, I think my observation has been that having worked as a CIO in the NHS using this system for about 12 years in total, that you're only really limited by your imagination. And that can be a real challenge at the beginning, can't it? Because when you first get an EPR, people very often can just remember a paper-based process, and it's really tempting to want to electrify that paper. Henry Ford is quoted as saying if he'd given people what they asked for, he'd have given them faster horses. And helping people to imagine what a car would be like in an environment where people travel on horseback is really tricky. And I think it's true in hospitals that as you move from paper to a system, having that ability to be able to optimize yourself means that it's okay if people weren't quite as imaginative the first time round as they could be, and they can then optimize and take out a whole load of checks and be able to build in the kind of either branching logic or automatic referrals or triggers or things that can really help to streamline processes, but which people might not have imagined otherwise. People are quite set in. I sometimes think about how I remember back to Gloucester and think about how the hospital was managed out of hours. People had to imagine that differently once they'd suddenly got access to all of the OBS for all of the patients across both of the sites, so that even though one hospital was 10 miles away, the acute care response team overnight could see within the Altera EPR that a patient was deteriorating 10 miles away, and they could ring the ward and step in, which they could never have obviously done on paper. And when they first take the system, they can't perhaps imagine just the potential and the difference that it can make for patients and for their colleagues.
Yeah, no, really interesting. And I guess that part of what you're describing there, Mark, is really the kind of operational, clinical, but cultural change that these kind of systems bring in and almost force. Would you say that's fair? I mean, I know it's quite a strong word, but it kind of makes you think differently, doesn't it? Because you have to think differently, and hopefully differently means better. than what you were kind of doing before? You got a smile on your face, but go on, do you want to come in and come in?
I think there's some truth in that. I was going to ask Joe really, because I think my experience has been that in some teams, people really grasp that and really run with it and have a million ideas, and it's brilliant and awesome for the digital teams to work with them to have a configurable product such as ours and be able to make the changes that they imagine and bring about those improvements. But I wonder, in a world where people are under so much pressure on the front line, where clinical teams have got patients in corridors or a backlog of patients in ambulances, how on earth do you create the headspace for them to think about that? And when they've got so many other operational pressures, I think sometimes you do find teams who really, they want things to be as they used to be, or they just don't have the space to be able to imagine it differently. And so I don't know, Joe, whether there's anything that you've been able to take from an area where people have had, ideas and be able to try and use those ideas to, help teams that are perhaps struggling to imagine what different might look like. How do you get those teams to think differently and really embrace the capability that they've now got?
Good question.
It is a good question. I think you're right, Mark. I think not everybody is as keen. There is always going to be some laggards. There's always going to be people late to the party, but they have to join the party at some point. I think one of the key things for us, really changing point, is that visibility point that you were sort of discussing there, Hadley, as well, and then seeing that, sort of having that suddenly, that the opportunity to be able to understand the status of the whole trust, at the tip of your fingertips. We had planned downtime recently, and that definitely demonstrated to me how much people, and I think they don't realize how much they rely and like it until it's taken away. And that was a bit of a shock. And even though it was planned and I think it was managed quite well, actually people then, and you forget, don't you? You very easily forget what it was like before until someone takes it away from you. And you have to then go back to those, 50 pieces of paper all over the place, trying to understand where people are in the hospital. I had, doctors ask me, but how do I know where my patient is? Like, they've been moved, I don't know where they are. And we still had the PAS system up and running, but even that, not having things at your fingertips that you're so used to. So sometimes you just need to take it away for them to realize how much they love it and how much they like it and how much they rely on it. I think for me, it's being out there. And we're probably going to talk about this more in detail, but I think it is being out there, listening. Just for that downtime, I did a night shift, and I went around all the wards, spoke to lots of different people, and so many people were saying, oh, can we do this, or could we have this, or how about this? And people do have those ideas, but they've probably not got the space to be able to communicate those ideas. Like you say, it is busy. When they get time to sit down and write an email, they're not going to write one to me. They're going to write all their emails that they need to elsewhere. So I think it is having that, being visible, and actually going out there and speaking to the staff while they're doing their jobs, because that's when they think of things. That's when they understand what their challenges are and how they need to improve them. So that's definitely helped.
So Joe, because I'm going to ask you a question, but then there's a pre-question to the question, which is kind of in terms of those usability kind of challenges, could you maybe name the top challenge and then kind of explain some kind of practical first steps that you would recommend, to a digital or clinical lead that's starting to tackle some of those usability issues within their existing EPR infrastructure?
Yeah. I think so I'll start with how I think we solved them, I suppose. I think listening to end users is the key. And I think that means getting out there, shadowing. In my opinion, that's the best way to learn. Hang out, go through the different workflows. What you think a workflow is 9 times out of 10 not what it is, because clinicians will do workarounds, will have 5 ways of doing that one thing that you think. So it's understanding what they are, because I think probably one of the biggest pain points for clinicians is that you are attempting to understand their workflow, and actually then when it is digitalized, it isn't what they do, and then they've got these challenges within the workflow that they have to then make their own workarounds for, because they won't tell you. They will just do things a different way. We know they do. I am one of them. So I think it really is, if you write a process map of what you think, it's then going out there and understanding if that is reality or not, and walking those steps and following those staff to really understand those workflows. I think so shadowing, getting out there, establishing sort of usability working groups as well with frontline clinicians and IT staff is really important. Having like you're saying, Mark, not that anyone's got much time, but if you can have a space where people can write down, somewhere for it to email, groups that can meet, clinical governance, like anywhere that you can get out there to really understand what the pain points are. We have luckily established a culture where people are not afraid to tell us when they are not happy with something. We're very clinically led in Maidstone and Tunbridge Wells, which means that I personally think that clinicians feel like they've got a voice and they are able to communicate when there is an issue or when something's not quite working for them. I think one of the pain points for us was definitely sort of the automation of data being sent on. So pre-populating is one thing and really, really useful, but pulling information automatically into fields was definitely something at the beginning we thought we really, really wanted, but then over time realised that actually you're then signing someone else's words, and actually, does this work for us as a trust? Do we want more free text boxes? You know, those kind of things. So it definitely built up over time, and we definitely amended based on feedback from staff. And then embedding usability testing, I think, as well into your change control process. So we have exemplar awards that will pilot everything for us before it goes out to the wider trust, to really get some honest feedback on their usability of whatever we've designed or whatever we've put out there, to ensure that if there is changes that need to be made, they're made then and there before they go out to the wider trust. And I think that really, really helps. It doesn't have to be perfect when it goes out there. We actually want that feedback. We want people to try and break it or challenge us and get it right, because then they feel involved in that process, and actually we've got a good end product.
Mark, do you want to come in on that? I know you probably got a few thoughts, but thank you, Joe. It's really insightful.
Yeah, well, I agree with everything Joe has said. You know, we really struggle to understand processes. You sit down with a team, and if you sit down with a team of 3, you might have 5 different views about what the process is, and probably more than 5 about how it could be. I think the ability to kind of be able to optimize your system is really important in that space as you go along. But I was just reminded of the number of times I've been to trust boards with business cases. You know, 3 times I've bought an EPR, and 3 times I've had a conversation that says we're about to buy a shiny train, but there's no point doing that if you haven't got some tracks to run it on. So, you know, one of the really important bits of usability is what's your internal infrastructure like? Does your Wi-Fi work everywhere? Are things reliable enough? If you are going on a ward round, can you put a smart card in a device, or connect to a device in one area, and then when you walk into another area, does that session persist and it takes you to exactly where you were? There's all sorts of bits of technology that are enabling, but really important in terms of usability. Usability isn't just, I mean, the stuff that kind of CLAS and Ethical and NHS England have done about usability says it's a third about picking the right solution, a third about having the right infrastructure. And then the bit that we can often skip over, a third about, have we trained people correctly? Do people understand the processes that need to be following, the scenarios in which they need to be using different systems? And so I think infrastructure and keeping investing in that, keeping exploring ways in which you can make that better. But then ongoing staff, we can often set ourselves a target, can't we, of making sure 80% of staff who are on shift in those first 2 weeks have been trained, and then we go live and celebrate. But what happens to the person who starts 2 weeks later? What happens to the person who starts 6 months later? What sort of training do they get in the EPR? What sort of training do they get about which documentation and what processes should they follow in a certain clinical situation? So I think usability is about all three of those things, and what you can do to make sure the organization, in kind of the broadest possible sense, is making the EPR as usable, accessible, quick, and easy to understand as possible.
And Joe, when Mark was talking about kind of, training and being aware of everything, you were smiling on that quadrant that he was describing. What were you thinking at that point? Were you thinking that's not what you did, or that is what you did, and that's why it was...
I think we definitely didn't get it right at the start. I think we did. I think the team did, because I wasn't there then. A very good job of ensuring that everyone was trained, everyone was aware, and everyone was on board at the beginning. But yes, I think we probably then overlooked, like so many trusts do, the sort of continuation of that training and support, especially sort of that digital literacy piece. We now actually think we've got it a little bit right, and we deliver, I hope, we deliver face-to-face training. And we are going a step further and using simulations and things for staff now, which it's taken us a good few tries to get where we need to be, and a lot of feedback and a lot of doing things wrong. But I think it's really important to be allowed to fail in these spaces sometimes, and to learn from them and move on. And I think we are in a much better position now. And yeah, we haven't got everything right, but we are in definitely much better position now. I deliver quite a lot of the training sort of face to face with new nurses that come in. We do ensure we've got preceptorship training. We grab all the doctors as well when they join. So we're definitely getting there, but I think you have to fail a few times and get it wrong to learn.
And actually, that leads me nicely into the next question, Joe, which you might have partly answered, to be fair, through what you've just said. But how do you ensure that clinician-led design becomes the norm, and not the expectation when kind of developing or improving EPR systems?
I think governance. I think it should be mandated. Clinical involvement should be mandated in sort of those early decisions, but also continued decisions. So we've got those formal roles for clinical informaticians now. So great shift to have CNIOs, CCIOs. Though I do personally feel this needs to be extended to represent all clinical roles. I cover HPs and midwives as well. We're lucky enough to have sort of a lead digital midwife, but there's probably not a full representation, and I think that needs to be extended on. Ensuring executive buy-in, that's, as long as it's not just lip service, they need to be visible, it needs to be consistent, the message needs to be really, really clear, the vision needs to be there, that everyone is aiming for that vision, and that needs to be fed down throughout. Allocate dedicated times for those clinicians, should I say. This is really difficult, and especially in the current climate, but I do think if you can allocate dedicated time, not just have those volunteers, you will get that sign up. We recently collaborated and delivered a sort of a fellowship-y course for our digital reps, that they could come on to sort of give them some validation in their roles, which was brilliant to have not just the digital staff in, but actually staff from all over join. So things like that really help to sort of make people feel like they are part of that journey. And a bit of a culture shift, I think, like the perception of an IT project to a clinical transformation project. You know, and I don't necessarily like that terminology. I think it's been used too much, but it really is. It's not an IT project anymore. It isn't owned by IT. It is owned by the trust. It is owned by those staff who are on the shop floor, and ensuring that clinicians are seen as equal partners, not just the end users. They need to be involved in that whole thing.
You're getting some thumbs up there, Jo. So just a question, then I might turn to Mark as well to see, you know, maybe from other Altera sites and in his experience, what his response might be to that question. But just a quick one. Do you think, would you say that your personal time is what you expected it to be when, you know, implementing and optimizing the EPR, or do you think it had to increase, or did you do less than you thought? You know, what, just from your time, because I know you spoke about training nurses and obviously being very hands-on, but just what's your kind of, you know, what's your experience on the time that you've had to invest?
Well, it's a full-time job. Literally.
Right.
No, we have an amazing we're really lucky. We've got an amazing team. Our team is bigger now than it was when we went live, and I think that's something really to be mindful of as well for trust, because you are growing as your system grows, and if you have flexibility within your system like we have, then, you know, you want things to be able to be done in-house as much as possible. You want to be able to control some of that, and share it afterwards. So yeah, our team is much bigger. So investing in that team is really important, really key. And then my job really then is sort of that, having that oversight of everything that touches everything to do with digital in the trust. So
yeah,
everything always comes back to the EPR, because that is our core foundation. But there are obviously many other things going on. So yeah, it's a lot of time, a lot of commitment, but I think, you know, rewarding, and it isn't just a temporary job, it's forever. You know, there's always going to be something else that comes up, a patient safety incident, or a mandate, or something else needs to be changed and improved and followed through, or more data to be collected, or whatever that is. But there's always going to be something else.
Yeah, no, for sure. So Mark, you know, in your experience around this kind of clinical-led design becoming the norm, what's your view?
Well, so I agree with everything that Joe says. There's just a few challenges with it, aren't there? If you do have, you know, a CCIO, that person might be an endocrinologist or might be an intensivist. How they can weigh in and contribute to, you know, redesigning a workflow from ED up to AMU is really difficult for that individual. So then they need to empower some people who perhaps aren't paid to do any digital stuff, and you might get 6 different clinicians all coming up with different ideas, and you tend to get a range of, in my experience, without, you know, being too extreme about it, you get people who understand the current process and would like to replicate that, and then you get people who would like the system to kind of read their mind, and somewhere in the middle is a requirement of not just understanding the clinical process and being able to reimagine that, but to also understand what the constraints are. So, you know, the trust has got a PC replacement, you know, policy. It's got so much capital money. You can't have everybody having a computer, a laptop, and an iPad. So how are you going to make this work? You need to understand what the technical capability is and limitations of your environment or your infrastructure. You need to understand how the system can be configured and how that best works with partners in other bits of the system if you're sharing information with primary care. So I agree with clinically led, but I think it's really important to say clinically led and digitally enabled, because if you just have the clinicians sat in a room reimagining these things, you can come up with some brilliant ideas, but the implementability, which I'm sure isn't a word, is non-existent. So you need some people who understand the capabilities of your environment in that room in order to be able to have a fully rounded conversation, and working out how to do that and how to do that on a repeatable basis. How can you train increasing number of clinicians in the capabilities and in the art of the possible? Otherwise, you either start imagining something that can't exist yet, or you're still using VHS tapes in a world where everyone else is streaming. And you just need to try and find a balance. I agree with clinically led, but I think it's equally important to say and digitally enabled.
Yeah, no, absolutely. Just going to look at some of the comments in the chat. Actually, Juliet from NHS England has put that they've recently run 3 webinars with NHS trusts where those trusts have shared how they improved their scores across 3 themed areas, which will give some more hints and tips. So, and there's a third one to be run on EPR training, and there's a couple of links there to the Futures site, NHS Futures site. So that's super, Juliet. Thank you. Just to build on from all of that, got a question, because you've led us in very well there, Mark. Thank you. Around kind of stakeholders involved in EPR delivery, obviously from suppliers to NHS leadership and all in between. Where does the responsibility ultimately sit, do you think, for usability, with all those different stakeholders? And you describe them as well, Joe, the governance, all the individuals, there's a huge ecosystem of people involved in making this successful. But where do you think the ultimate responsibility lies for usability?
Are you asking me? Sorry.
Yeah. Well,
sorry,
both of
I thought you were.
You go first. You go first. It's both of you.
I think it's shared. I think it has to be shared. Leadership's got to sit within the trusts. The vendors build the system, NHS bodies commission them. I think NHS leadership has to set those clear usability standards and embed them into procurement and assurance. I think we need to sort of have those standards, and trusts must enforce those expectations, but ensuring they've got that strong clinical involvement, and vendors must respond. I think, sorry, Mark, but I think the usability needs to be treated as a non-negotiable, like cybersecurity or data protection is. I think it's just one of those things that needs to be looked at as as high up there as cybersecurity. I think it's key in us moving forward. It's when you've got poor usability, you've got safety issues, and it's probably not something that's discussed enough, because things are being discovered now rather than because there was such a drive for trusts to have EPRs. I think now we're sort of looking back and actually then analysing how sort of usability and buy-in and can it impact patient safety if it's not done right.
So Joe, do you think that poor usability is now one of the top kind of patient safety risks in digital? And if so, why do you think it's not kind of more widely acknowledged?
Yeah, I think it's definitely a problem. I think if clinicians have to battle clunky interfaces, or as I was saying earlier, sort of having to log into multiple systems, these things should just be not even an option for them anymore. I think we've got the issue with alerts overload, or poor information visibility. It increases cognitive burden on our users as well. Could be delays in decisions. I think they are underreported is probably one of our main reasons why it's not as much a key issue that has been addressed. I think it lacks a shared metric or clear accountability. Where does it lie? And I think there is still a huge belief that clinicians should adapt rather than demanding better tools and demanding better EPRs or better digital systems. I think they do naturally. adapt. So then they hide things. They might moan, but they do adapt. They do find workarounds. So therefore, we're not holding the right people to account to ensure that we've got better usability.
Yeah. Okay. And Mark, then if you want to come in and comment on that.
Yeah, I mean, EPR's just like healthcare in general, isn't it? Which is that it's a team sport, and it requires all of us working together. We work really hard to make sure that our clients understand that we want to be part of that team. We want to be part of how an organisation makes care ever more safer and reliable. I think that's but that does require a culture shift in an organisation. And these things take time. I was telling somebody the story the other day of how when I worked at Southend Hospital, I was experiencing chest pain. I went to the A&E there, checked in, said that I'd got chest pain and shortness of breath, sat down, and about 3.5 hours later, I went back up to the desk and said, look, nobody's seen me. I feel really unwell, kind of what's going on. And the receptionist walked over to this big printer and kind of moved it forward and peered down the back and then pulled a bit of paper out. And she said, are you Mark Hutchinson? I said, yeah. She said, oh yeah, some of the paper gets lost down the back of there. It comes out of the wrong bit of the printer. We'll get someone to see you now. And we don't recognise, and nobody, I'm sure, put that on Datix, the harm that paper brought. But because it's new, we do have an opportunity to capture the opportunities that can be, the improvements that could be made with digital. I think encouraging people to understand all harm in the system and then working out how do you include the digital team in the design of every solution. So wherever the problem was, whatever the Datix, whatever the issue, whatever the risk that's raised, how can digital be part of the answer? Whatever the problem, because we continue to design otherwise, don't we? Analog alongside digital solutions, whereas digital first needs to be more than just a strapline. It needs to be the way that safety improvement, quality improvement, trust boards think, and I think that's part of the culture shift that we're still trying to navigate within organisations.
I just to come in on that, Hadley. I think you're completely right, Mark. And one of the things that I've really tried to push over the last 3 years is to bring digital into everything, just as in everything. So we've got a mental health committee and we've got a digital work stream, digital and data work stream. We have a native life care committee. We have a digital and data work stream. It does mean I go to a lot of meetings, but it is just the standard now. In every single work stream, every single committee or every single focus group or every single working, that digital and data is part of that. And that's been a huge change for us. And that has been that culture shift, where actually we're then looking at how digital and data can support or how they can enable or how they can transform whatever they're trying to do in those pathways, because they've identified a problem. And it's not that digital's the problem, it's how can digital support improvement and enable either clinicians or the patient's journey or the experience to be better for them. So, and I think that over probably the last year has just creeped in and been the norm, and that is when I've seen a massive change in our trust in how they're sort of really understanding data and digital and how it fits into their lives. It's just norm.
And what does that look like now compared to before, Joe? Is it it's just much more visible, it's reported, it's spoken about at exec level, there's good governance? Is it all that kind of stuff, but that just didn't exist before?
Yeah, and I think through no fault of anyone, I think it's just we had such a big focus on getting the EPR out there. I don't think anyone realised what it would then look like on the day-to-day normal. And I think also we might have responded to problems without thinking about the whole pathway and how. So someone might say, this isn't being done at a field. And that might be something we did at the beginning because that was sort of an easy way of recording that information now that we didn't have before. But now we say, actually, let's look at the whole pathway. Let's understand the problem. Let's go through everything and then understand how it can enable and support, rather than just trying to fix a problem that's not going to go away if you just tick a box. So it's definitely sort of embedded, and that's come from the top down and the bottom up, I think. It is just normal now. It does mean that it looks like a lot of meetings when me and my colleagues go to, but I'd much rather do that and be involved wherever possible. And sometimes the right solution might be to start it on paper, but start it on paper for whatever reason. But it's then giving people the opportunity, the options, letting them understand. And like you said earlier, Mark, about sort of getting the clinicians to really understand the capabilities rather than their pipe dreams, because we have to say no sometimes and we can't do everything. We've definitely done that through being more visible, being in all these groups, explaining what the capabilities are and what we can achieve. There has definitely been sort of that learning culture, and by getting people more involved in those discussions.
Yeah, 100%. It sounds like the role that you're describing, Joe, is probably not what you thought a chief nurse would have been doing, even 5 years ago, maybe, compared to what it is now. So it's obviously cultural change at kind of all levels, isn't it, really, to kind of make that happen, which sounds super. I guess, a question maybe for both of you, really, what role, because obviously we've spoken about a lot of kind of issues, a lot of practical tools, a lot of kind of change, and things that have to kind of move in that order to kind of make this successful. But what do you think, what role do you think cross-industry collaboration like the EPR network can realistically play in kind of driving usability improvements at a national level? And how can we get people involved in that? What do you think, Joe?
Well, it acts as a shared intelligence hub, doesn't it? I mean, it's brilliant for identifying common issues or challenges across systems. Spotlight in solutions as well. We share a lot within our group. Helps avoid duplication, can reduce costs, and sometimes can collectively bargain with suppliers around expectations sometimes, or deliverables. I mean, ultimately, I see the point of them is to co-create best standards, best practice. We've all got the same goals, so why not share, develop, learn? We've got a group that we literally just type in a chat and say, anyone got any ideas on this, or anyone thought of this, or anyone done this yet? And it's so fantastic to have those connections.
Yeah, no, awesome. Mark, obviously, do you want to come in and?
Yeah, I mean, it's so important, isn't it? If I think back to my time at Salford, we implemented our EPR in 2012, I think it was. So that's 13 years ago this week or next week. We don't always do as good a job as we should of sharing the lessons that we learn, of the ideas that we have, of the things that have gone right and the things that have gone wrong. We definitely don't find ways of sharing things that have gone wrong. I think we're often too busy to even share the things that have gone well. But certainly, so understanding how you can do that and getting people to engage with that. Somebody's just put blueprints in the chat. How do you make sure that blueprints from an NHS England perspective are ones that are supplier agnostic and pick up on not just specific pathways, but understand how they hook into the different ways that different areas, different system configurations might suck other information in. How do you make sure those blueprints are then kept up to date with something that's been done that's built on that, and perhaps improve that in a different part of the country? We put a lot of effort into our kind of the Altera blueprint, and we take the best that MTW have done and the best that Dudley have done and the best that Worcester or Gloucester have done, and offer to people, this is so far, but then how do you build on this was the best that anyone had done last year, but this year somebody's built in a whole load of new capability, and then how do you? So I think that it's a really important space. Perhaps there's quite a demand on your time. I think if you went to every one of these, every NHS England session, spent a lot of time on the kind of website trying to dig your way through blueprints, you'd struggle to fit kind of your job in. So working out how we can do all of those and how we can focus that, or how we can make it easier for people to access that, because I do worry that in the meantime, because it's a bit difficult to navigate all of that, you just stay at home and then end up reinventing the wheel that somebody else did 7 years ago. So somewhere in the middle, there's a fine line. That's great, Julia. I'm really because working out how to make it as accessible as possible is so important, because with the way funding is at the moment in the NHS, with the challenges that every team have got, we don't have the luxury, do we, of using taxpayers' money to reinvent wheels. We need to find ways of sharing everything that we possibly can, and I think we've got a role to play in that. I think NHS England clearly have got an important role, and organisations like yourself, Hadley.
Yeah, no, that's great. Thank you, and thanks for those comments in the chat, Juliet from NHS England. Obviously, very happy to speak offline about how the EPR network could perhaps help curate and support those blueprints being developed. But it sounds like they're also in train, which is great. And I think that that kind of sharing, I think, of knowledge across the country and trying to bring it into a form that kind of makes sense to the masses is obviously really important. There's some questions coming through, so we'll try and get to some of them. There's one question that I wanted to get to, and there's one in the chat. So Joe, how do you make sure that usability improvements are ongoing, both from the trust and the supplier perspective? How do you keep it going and kind of relevant?
Build those relationships. I think we are really lucky. Well, we've worked hard as well, but we are very lucky to have a good relationship with Altera. I think there is mutual respect there that has built up over time, that actually they understand our knowledge and capabilities within our team, which are huge because they're fantastic. We have a configuration team, we have a business change team, we have a training team, we have a testing team, and they have grown and adapted and developed massively over the years. And sort of Altera really understand how we work. I think sharing practice is really, really important. And actually blueprints do that, because we have done one and we're doing another, so be happy to know. I think again it is really good. It's sort of understanding what others can do, understanding what the capabilities of your own system are. Keeping those relationships. I listen into staff, so I've said this at the beginning, but we do have quite a lot of groups. So we have digital reps, which again, it is a voluntary thing, but we offer courses time. We provide links for them to develop themselves as well, and we do shadowing, etc. But we also have digital fellows that it is extra onto their roles. So we've got a few doctors smattered around the trust, but that's helped massively as well. So as an example, we have a monthly meeting with ED with all the right colleagues in the room, to discuss any issues, challenges that they have within ED. I go to clinical governance every month, and I have a standing agenda for digital, so I will update on any changes. I will get feedback. I will get them to approve certain things, because if it goes out there and it's a surprise, guaranteed no one will like it. But if it's something that they feel they've been able to comment and be involved in, then it's going to be more successful. So yeah, there's loads of ways, I suppose, to get out there and just make it the normal. Like I was saying previously, it's ensuring that it becomes, it isn't just something that people think about afterwards, or they only think about when a problem occurs. It is something that's built into daily life.
Sounds like you've totally kind of weaved it in there, which is
I'm
awesome.
very
Yeah, no, but that's great. So what we're going to do, because time really does fly when we're having fun. There's 5 minutes left, but just a few slides that we want to go through. I'm just going to go through them, and then I'm going to come back to each of you on your kind of top tips and top lesson learned and kind of takeaway for people after today. So I'm just going to come onto a couple of slides really. So we've spoken a lot today about the EPR network. It's the only network of its kind in the UK. It brings together healthcare leaders, suppliers, vendors to collaborate and share learnings. We're also speaking with NHS England about involvement as well. And as part of that, and in partnership with Convenzi's group, we host a number of kind of regional and national healthcare events specifically around the EPR. So some of you may have come to the EPR Summit last year in Leeds, this year in London, next year in Birmingham, which I'll kind of get to. That's the annual event, and then we're very much kind of coming to all corners of the UK and planning to come to Scotland, Northern Ireland and Wales, and you can see the dates that we have there for those two events coming up. And I think, if I'm right in saying, there's a couple of QR codes, so if you're interested in coming to the Wales Summit, please take a picture of that QR code and register your interest. So I'll leave that up for a couple of seconds. And that's really about how we can adapt kind of insights to shape a scalable EHR, as they call it in Wales, solution for that corner of the UK. And then there's the annual summit that we have the date for as well on the 11th of February next year. So again, please do take the QR code and join the waitlist for that. We had just under 300 people last year, so and spaces are limited, so do try and get in as early as you can. Obviously, you can connect with us offline. Very happy to connect on email or LinkedIn. But just with a minute each, I suppose, to go. Mark, do you want to go first on your kind of top takeaway from today's conversation?
Yeah, I think my top takeaway is, we say that raising it takes a village to raise a child. That you need a whole bunch of different stakeholders who need to be in it for years, and the requirements obviously change as the baby becomes a toddler, becomes a child, becomes a teenager. I don't think it's that dissimilar for EPRs. It takes a team to make this stuff work. It takes a team to help a system become embedded and mature, that each stage along the way requires a different set of inputs as people become more and more familiar with it, and to stick with it. And a number of people have said, that's an ongoing investment of time, of energy, of money, to make sure that it becomes a really kind of well embedded, fully understood default way of the organisation behaving and providing care.
No, great, Mark. Thank you. And Joe?
Yeah, I agree. I suppose I have to say, listen to the front line early and often. Continue throughout. Don't just stop because you've gone live. I think that's really, really key. Shadow, understand those workflows, the actual workflows. I think definitely understand those pain points. Try not to give them 50,000 clicks just to order a medication. Build with the clinicians if you can, not just for them. Start with high impact, low complexity wins, just to really sort of boost morale and build that momentum to get things moving. Treat it like a living system, like a bit like what Mark just said. It isn't one and done. like you have to have continuous improvement cycles all the way through. Like it will never be over. And then finally, celebrate and share wins. I think it's really important to make sure that, you know, we are sort of flying the flag and singing from the rooftops when we've done well, and learning from them, but also when things go wrong. And I think you're right. It is hard to share those, but actually failure needs to be looked at as a positive learning point rather than something to sweep under the carpet.
No, thanks, Joe. We've had lots of complimentary comments in the chat. So just to say thank you to you guys, you've been superstars. Totally agree with all of those points. I think the one thing I was going to say was just commitment. You know, there's a real commitment to this thing. It's a bit like having the child or getting married or, you know, getting a mortgage. You know, these are big lifetime things, aren't they? It's not just a quick fix, a quick win, something that goes on, gets plugged in and then you forget about it. It's an ongoing commitment, isn't it? And that dedication and kind of drive from at all levels, I think, is what makes it super successful. So thank you very much to everyone that's joined. Thank you to everyone that's contributed to the conversation. Thank you to Mark and Joe for their contributions. We will share the slides, we'll share the recording, and hopefully we'll see you on the next EPR Network webinar series online, and hopefully in person as well in Wales in November. Have a good afternoon, everybody, and thank you.
Thank you.
Thanks everybody.